Thanks, everyone. Thanks for having me. Thanks for coming to the talk. I work at Christiana Hospital in Delaware, and I'm going to be talking to you about how you should be reimagining your approach to the management of tension pneumothoraces. Certainly have no financial disclosures to make, but I do want to disclose that I think I have a fair amount of job security because I work in a place where, unfortunately, we see a fair amount of gang violence. And we'll get a fair number of these people come in with horrific injuries. They sometimes get dropped off at our doorstep. And if there's anything I've really learned over the last several years, it's that these guys are easy to identify because they have two characteristics in common. They're often just standing there minding their own business and often getting attacked whilst doing something fairly innocent. But they might come in with a fairly horrific injury like this, a tension pneumothorax. And so what do we traditionally do with this? We'll put a large bore needle into this space to decompress them, second intercostal space, mid-clavicular line, hopefully hearing a hiss of air, hopefully improving the physiology, and thinking this is a really great procedure. We'll give each other a thumbs up, high five, and kind of move on to this. But how good are we really at really adopting into practice what we've learned through the years in our training? This is a study from my colleagues in Ireland that actually looked at this, where they asked a number of emergency medicine physicians and residents to just point out on the chest where they would decompress in that traditional teaching. And the majority of people end up putting the needle actually a bit too medial, risking injury to the great vessels in the heart. And unfortunately, I've had in my career the events of managing a couple of these cases where they've had these misplaced needles. And quite worryingly, a couple of people thought that this place was the right place to decompress a tension pneumothorax. So I'll leave you guys to decide about that. So I think there's a mounting body of evidence now that supports our move from the second intercostal space to actually moving the needle to the fifth intercostal space, anterior axillary line, for decompressing these tension pneumothoraces. And in a select group of patients, even thinking about increasing the size of the needle you're using, so going from the standard 5 centimeter or 2 inch needle to maybe an 8 centimeter needle. And I'll talk about those in a bit. One of the kind of landmark studies that was looking at this is this one out of LA that compared chest wall thicknesses on CT of a variety of patients presenting with chest trauma, and found that if you're using that standard 5 centimeter needle, you're only going to get the pleura in about 60% of the cases at the second intercostal space, as opposed to over 80% of the time if you move to that fifth intercostal space, anterior axillary line. So certainly making the case to move your position. This paper came out last year in Injury, systematic review of almost 35,000 patients, and found again that the chest wall thickness was about a centimeter more at the second intercostal space as opposed to the fifth, and again that led to higher failure rates when this was used. So more argument to push to moving your needle position. But that requires change, and we just heard a talk about change, and that's difficult to do, especially when you've come through decades of training and teaching where you're using that second intercostal space. So is that something that you can possibly do? Again, my colleagues out of LA looked at this and got 25 paramedics, really experienced ones who were traditionally taught, like you and I were, to use that second intercostal space to decompress these tension pneumothoraces, and gave them a little bit more training and then sent them out to the cadaver lab to see if they could decompress in both of these spaces and compare the outcomes. And consistently they found that at the fifth intercostal space, these guys were much more accurate, much more closer to the mark, actually about a centimeter off in some cases as opposed to 3 centimeters in the second intercostal space. And certainly this was felt to be easier to do, and they actually did this in the same amount of time as they were doing traditionally in the second intercostal space. So you can change culture with a little bit of training. But we're faced with another problem here in the United States as well. We are getting patients who are larger. There's a big obesity crisis here too. And certainly they come to our ED with a bunch of medical problems, but they get traumatic injuries as well. And so is our choice of needle appropriate for these patients? This paper looked at just over 300 patient CTs with people of varying BMIs. And not surprisingly, they found that the higher the BMI, the higher the chest wall thickness. In fact, the mean chest wall thickness at the second intercostal space was about 6 centimeters. So that 5 centimeter needle that you're traditionally using is never going to reach the pleura in these people. This was a paper out of Canada looking at about 800 patients, not just looking at differences in BMI, but also looking at differences in sex, and found that about 20% of men and about 35% of women had chest wall thicknesses that was larger than 4.5 centimeters. So again, your 5 centimeter standard needle may not reach the pleura in these subset of patients. So a case to think about stocking those longer needles in your practice. Now, some of you in the audience might think, well, you know, you've heard a little bit about this before. It's certainly been in the literature, and you're right, because this is something that was discussed as far back as 1996. But it keeps coming back in the literature. And the latest annotation of this was the study I talked about, that systematic review that came out last year. And this past year has seen a lot of stuff in the foam med community as well, in terms of podcasts and blog posts about this. But what was the true evidence that eventually all this paper evidence goes into practice was that the holy grail of trauma care and trauma training in the United States, ATLS, in its next edition will be adopting this as a change in practice to move your needle to the 5th intercostal space anterior axillary line if you're choosing to decompress for tension pneumothorax. Now, of course, if you have the skills, remember that an open thoracostomy or finger thoracostomy is a much more effective procedure to truly decompress and reverse the tension physiology that these patients have. But certainly, if you don't have those skills and you have to resort to a needle, I'd strongly advise, and I hope this short talk has changed your minds also, that you should certainly consider changing to that 5th intercostal space position and certainly consider stocking that longer needle just for those subset of patients, for example, with a higher BMI that might come into you with traumatic injuries. I want to thank you for your time.